to lower this, I'm so short. Hi everybody, thank you so much for inviting me along today to present about inductions and sections. I'm going to be honest, I'm going to say that normally I'm asked to present on either water births or on the midwifery-led unit, so inductions and sections is a new topic for me today. And to be asked to do it in 20 minutes was really, it's very much a whistle-stop tour, because when I started delving into it all, I think I could be here for hours. And also probably a lot of the stuff that was discussed this morning, I'm covering again today, so it's probably just supporting what was discussed earlier on. So kind of things I'm going to talk about today is what are the trends over the last 10 years and what are the influences or some of the influences that, on those trends. Induction, expectant management and spontaneous labour. What are the risks? How is it affecting normal risk care and what we as a community of midwives can do to change the tide. So I'm sure you're all aware, I know it was talked about this morning, about the Irish maternity indicator system that looks at the induction rates in Ireland. And over the last 10 years, it's gone up easily by 8%. That means that now currently, in 2023, we're looking at a percentage rate of 36.9% of women in Ireland being induced. I don't know how you feel about that. I am just stunned to think that we need to manage nearly 37% of all women, and we need to manage their birth, that they cannot birth themselves without us inducing them. And when we look at our section rates, we can see that since 2014 up until 2023, it's gone up by 10%. So 40% of our women are having a surgical procedure to deliver their babies. I mean, it's actually shocking when you think of it. So what's influencing this trend? Women's choice, of course. Public versus private. Now, I know the system has changed a little bit, but still in our voluntary hospitals, as we know that 20-30% of funding comes through private care, and that still is a driving trend. So you're more likely to have an induction and a caesarean section if you are a private patient. Pre-labour rupture of membranes, gestational diabetes, large gestational age, intrauterine growth restriction, the list goes on, reduced fetal movements and the new guideline with that, preeclampsia, increasing BMI and post-AIDS pregnancy. And that's a big one now at the moment, is the new national guideline on post-AIDS. And the big one is, overall on this, is risk, risk, risk. So what is risk? I think Rachel Reid said it really well when she said, everything we do in life involves risk. So when considering whether to do X or Y, there's no risk-free option. All women can do is choose the option with the risks they're most willing to take. However, in order to make a decision, women need adequate information about the risks involved in each option. So are we really giving them the adequate information? And if we are giving them that information, are we giving it to them in a manner that they understand, in a health literate way, that they can understand what the real risks are? In Our Lady of Lourdes Drogheda, where I'm very fortunate to work, we have the midwifery-led unit. And with that service, we have an opt-out service. So that means if you're low risk, you are automatically sent to the midwifery-led unit, and our care, I'll tell you later on about it, starts at 26 weeks. In 2023, we saw 27.5% of all the bookings in Our Lady of Lourdes in the North East, and in 2024, 29.5%, allowing for a certain percentage of women that choose to have CLU care. That means that it's kind of about 32%, that only a third of our women entering into the hospital are actually considered low or normal risk. Like 30%. How is that the case that when you come in, you are basically risked out straight away? You're considered, you're a risk, you're a risk, you're a risk, and you're risked out of that normal low risk care. So, looking at some of the things that affect that, we have to look back at the two big studies that have been done, which is the ARRIVE study and the Cochrane review, which has heavily really influenced our national guideline now. So in 2018, the ARRIVE study was out, and both these studies looked at induction of labour beyond 37 and 39 weeks versus expectant management. So So the findings, risks of stillbirth per 1,000 births was at 37 weeks, you 0.11% in 1,000 births of a stillbirth. And by 42, 43 weeks, you're 3.18% of a chance, or 3.18, not percent, sorry, apologies, 3.18 of 1,000 births will be at risk of stillbirth. Taking into account that some of these women may be, because the ARRIVE trial was done in America, may have not had the same health qualities as others, the risk for low risk then would be, per 1,000 pregnancies, would be 0.12 to 0.88 at 42 weeks. So what is the limitation of the ARRIVE study? So there was a low participation. Only 27% of eligible women chose to participate, suggesting that the majority were not in favour of being induced at 39 weeks. The context limitations, the findings mainly apply to women cared for by private obstetricians in the US medical setting, where caesarean rates are higher and spontaneous vaginal birth rates are lower compared to other models of care. Notably, 94% of the care was provided by obstetricians and only 6% was provided by midwives. I can never say this word. Methodological concerns. Care providers were aware that the study, which may have influenced their decision and intervention thresholds, the impact on caesarean section rates. There was a reduction noted from 4% reduction in caesarean deliveries. However, other factors like continuous midwifery care that we discussed earlier on, birth location, labour monitoring methods, and had a greater influence on caesarean section rates. So if you look at continuity care models, would actually bring those caesarean section rates lower and would have more of an impact. And the outcomes for babies. So inductions had no significant effect on the immediate health outcomes for babies. However, the study didn't examine the potential effects, long-term effects of early birth, such as impact on brain development or on breastfeeding. So I suppose in my naivety, when I looked at this study, I assumed that induction was versus spontaneous birth. So I had to have a little look closer at this. So determining whether induction of labour reduces the stillbirth compared to spontaneous labour is challenging, because the comparison is between induction at a specific gestation, i.e. 41 or 39 weeks, and expectant management, which includes induction after the specific gestation, induction for complications, and spontaneous labour. So it's not induction versus spontaneous labour. Expectant management is a very different thing. You know, when you think of it now, like a woman could decide at 39 weeks she didn't want to be induced, but decided at 39.05 that she wanted an induction. Or she may have come in with a non-substantial APH, and that would have been increased an episode of reduced fetal movements, decide to induce. So it's all these factors as well that has influenced it. So what's happening in Ireland, I suppose. So first of all, the NICE guidelines were updated in 2021, which looked at some changes to the induction of labour guideline. And then our own national induction of labour guideline was released last year. So what are the benefits of induction in normal risk pregnancy? Inducing labour can allow planning for both mother and baby, both mother and healthcare team. It may facilitate scheduling of hospital resources and support, which can be particularly helpful, obviously, in situations where logistical factors need to be considered. Induction labour can accommodate the preferences of pregnant women. If a woman prefers to have a planned birth or wants to avoid going past her due date, induction can provide the opportunity to align with her preferences and create a personalised birth plan. And inducing labour in post-stage pregnancies can help reduce the small risk of stillbirth. However, what are the risks of induction? Women should be informed that induction is a medical intervention that may affect their birth options and their experience. They should be aware that it will impact on their place of birth and may affect the duration of their hospital stay, can impact on the need for pain relief, as induced labour may be more painful than spontaneous, results in an increased number of vaginal examinations as they're required to assess the cervix and monitoring progress. It results in an increased level of fetal monitoring. Induction may be unsuccessful, leading to birth by caesarean section, and induction labour may lead to uterine hyperstimulation, cord prolapse, and uterine rupture. So how many of us really sit down and go through this in a way that women understand? When they talk about inductions, do you see them sitting down and saying, okay, so these are your risks, this is what your benefits are? Or really, not very often are we seeing this happening. Also, what are the, factors that are potentially driving the elective caesarean rate? As earlier on, we were discussing about that fear and perceived trauma. So I think when we talk about fear and what's driving that, is it actually fear of an elective section? Or is it fear of, say, blood? Is it a fear of the hospital itself? Is it a fear of having, needles? What is the actual fear? So when a woman comes in and says that I'm afraid of giving birth, are we actually sitting down and discussing with them, what are your fears? Every unit is different, obviously. So some will have more midwifery influence, but realistically, it's probably a lot of the time the obstetrician who's sitting down and talking to that. So is it really discussed with them? Repeat caesarean sections. If we can get in there before the very first caesarean section, as Mary was talking about earlier on, I do think that would make a massive difference, to what it is. And how can we do that? So we know that our continuity of care model works. We know that the community midwives in Holles Street work, the MLU care works, and we'll talk about that in a few minutes. And the influence of social media. TikTok, Instagram, how are we getting that information out to women? Is it there for them? Is it easily accessible? It's really not, and as, again, was discussed earlier on, that access and where they access it and how, it's really not like information. They're getting it from other people, other influencers who are giving that information out, and it's not from the professionals. I know it's quite difficult in our hospital to get a Instagram page. We're lucky and fortunate enough in the MLU to have a Facebook page, but it's not a hospital account. They have to go to the hospital website to get it. We do provide a QR code at booking, but again, it's giving them that information and making it easy and accessible for everybody to get. Increased comorbidities. So, fortunately, nowadays, women who, say, would have been insulin-dependent diabetic in the past may not have carried to term, and that's a great thing now they can. So they may be opting for an elective caesarean and need that caesarean section. And that is good, that's something that is positive with that. But that is one of the ones that's driving the sections. And then a rise in fertility treatments again. Like a lot of women now, older moms might just say, oh, I'm just going to have, one baby now, so I'll have a caesarean section, but not really know the risks behind that because they feel it's a safer option is to go for a caesarean section. Oh, sorry. And again, kind of looking at that Robson group, this is really who we need to be tackling at the start, that group 1, 2 and 3. If we can get into there before, we have amazing MBAC and BBAC services all over the country provided by our fantastic AMPs and midwives, but it's to get in there before they even need to get to that repeat caesarean section stage or to get in there before they have to sit down and explain the advantages of not going. Why is it at that stage we need to explain the advantages of not having a caesarean section when we could be getting in at the very beginning before they ever have that first section and explain what the advantages are of not having a caesarean section and trying for a vaginal birth? So what information do we give and when do we give it? So when the induction of labour guideline came out, it really, affected a lot of our care. We looked at in the midwifery-led unit that approximately 20% of our women would go past term plus 7. So it's the question for us is at what stage of the pregnancy were we going to give this information and go through what the risks and benefits actually were. We started giving this information out at 39 weeks gestation. And I know the NICE guidelines would recommend starting off that induction conversation at a much earlier stage in the pregnancy. Our fear was it kind of giving a seed of doubt into women before they even start their whole pregnancy journey about, initially straight away we'll talk about induction because you probably can't do that. However, what we're finding is that when we're discussing it at 39 weeks gestation is that a lot of women are probably tired at that stage of the pregnancy when they hear that word stillbirth or 3 in 1,000. All of a sudden they're straight away, I'll obviously go for induction. I'm not going to put my baby at risk, even though that's small risk for a particularly low risk cohort of women. So it's really a question about when we have that discussion with them. I don't have the answer. And how is this affecting the care that we provide? So you can see here, this is just, again, the IMIS report. And this is looking at induction of labours of all mothers. So over the years, the MLU is in the green, Our Lady Lourdes in the yellow, and the red is our national figures. So over the years, we were generally lower. We spiked a little bit back in 2017 when we were an opt-out service. When we became an opt-out service, settled back down then as people got used to that. Spiked considerably then again with COVID over kind of 2021, 2022. We were dropping again then as things were settling down post-COVID, and now back in halfway through 2023, we really implemented our induction of labour post-dates guideline, and that's really spiked us now well above, and having that discussion. You can see how it's affected our primaps, and you can really see how it's affecting our multips. And that's the biggest thing we've seen, is our multips are opting now for an induction. More so, it's doubled in the last year of our multips opting for induction of labour. So, doesn't sound very positive, does it? But what are the benefits then of providing midwife-led care for the normal risk woman? I just want to talk a little bit about what our service is in the MLU in Drogheda. So we're a small group of midwives. We have 12 whole-time equivalents and 2 healthcare assistants. As I say, we see approximately about 30% of the women who attend Drogheda. We see them from 26 weeks. They have to be normal, low-risk pregnancy on the supported care pathway. We provide antenatal care to include clinical assessment, bloods, review of scans, education and advice appropriate to gestation. We share the care with the GP, so in between the appointments with us, they visit their GP. We bi-directional transfer with the booking consultant, and we do actually have a really good relationship with obstetric colleagues in the hospital. And if there is a problem that just needs to be reviewed, they'll happily see them in their clinics and then transfer care up if everything normalises. We have antenatal outreach clinics in Balbriggan, Dundalk, Carrickmacross, and they are really successful. And we also have ultrasound scanning for presentation with suspected breech, which means that, again, it's remaining within the service. We don't have to transfer out, so everything's done within the unit. We provide intrapartum care and support. So that sounds like such a small line, but it really is supporting that normal physiological birth and water births as well. We provide postnatal care, including a 6-hour discharge and care in the home for 7 days. And that was so important when you heard what they were talking about this morning, about that postnatal care that we give. We phone our women each day. We have a lactation consultant that works in with our unit and that goes and visits them at home as well if they're having breastfeeding issues. We can go out and do more visits. We generally do about 2, but we can do 3, 4 if needs be, and they can come back into us. And we also have a 24-hour baby check at home that we can do. So again, they don't have to come back into the hospital. So it really is, I know we talk about MLU services, but it really is that continuity of care package that we're seeing the women throughout the pregnancy. You can see that, I think, our successes with regards to the mode of deliveries for clients booked to the MLU. So they may have started out the pregnancy low risk or normal risk. They may have developed gestational diabetes, blood pressure issues, IUGR, larger gestational age. There are obviously complications within the pregnancy. However, even if they come to our clinic once, twice, and get that education and support from midwives at an early stage in the pregnancy, you can see our caesarean section rate is at 23%. And again, you can look at that really overall when you see what the national Our Lady Lourdes Hospital is and the national caesarean section rate is, and how we're down quite low. Again, I think with regards to Mary talking about that community care midwifery in Hollis Street, it's fantastic to think there women, 10% section rate, having that community care for those low-risk women, it's fabulous. Our home birth in midwives, it's just such a service that we as midwives can provide, and they're the real care that can show you how we can get those section rates down. Like when you think of the studies that were done and looked at our normal risk, they're saying, oh, we could bring it down from 22 to 18. That's still at normal risk at term, but if you were to take out the figures of the women that were still normal risk at term, our section rate would be much, much lower again. You can see the section rate for the primaps, and then for the multips is way down, which is fabulous. And again, that's showing you that when you have a vaginal birth the first time, how you can go on and have a successful birth the next time, vaginally. I would actually be killed by my director of midwifery, Gráinne Milne, if I didn't mention our water birth service, because she was such a support for us in that, and really is a powerhouse of a woman with regards to the care and the way she supports us in Our Lady Lourdes in Drogheda. So last year, 34% of our prime-ups had water births, and 48% of our multiples, with a total of 44% of all our births in the midwifery-led unit were water births, which was fantastic. It's such a success to see. So how can midwives change the tide for all risk women? I think it has to go two ways, from the top and from the bottom. So we currently don't have a chief midwifery officer in the Department of Health. We have our chief nursing officer. We're under the same branch. We have our midwifery advisor, but there's no chief midwifery officer. Considering we are all affected at some stage by midwives in our lives, whether we're born, whether we're mothers, whether we have partners that have babies, we're all affected by a midwife at some stage. Yet we still aren't recognised as a separate profession within the Department of Health. We still come under the branch of a chief midwifery officer. And I really believe that to come from the top down, to show that leadership at the very, very top and say, yes, it is a separate profession, that in itself would really drive support for us midwives. Antenatal, interpartum, postnatal supportive care guidelines. They've been in the pipeline for quite a while. I know that it was discussed this morning that it's taken 3 years. We still haven't seen them. Hopefully it is this summer. Really hopeful, because I do believe that for us to have our own guidelines to give us the support in our care pathways will really help us as well. And again, I know they are guidelines. I know that we need to think of the women that are out of guidance, and I know that Mary Renfrew was talking about those women this morning as well, those women that were out of guidance, and I don't feel that here in Ireland we really are supportive of our out of guidance women. I think that our out of guidance women can sometimes experience a lot of the fear mongering that was discussed earlier on. You know, they're nearly forced back into a system. They're forced with options of free birthing. They're forced with options of, you have to pay privately to go to your private midwives. If you have the money to do that, that's fantastic. But if you don't, then you're forced back into that system that's not supporting what you want to do. And if you know what you want to do, and if you've received all that information, and if you know what the risk is for you, and you're happy to take that risk, I still don't understand why we can't give those women the support that they require. Again, with midwives supporting midwives and that share and collaboration, in Ireland, we tend to work in silos an awful lot. And, I know with sláinte care and the guidance around that, but I do think that there's a lot of fear about picking up that phone and saying, do you know something, I'm not too sure about this. You guys are doing that better. What can we take on board and what can we implement? It's nearly like we're failures if we have to admit we're not doing that so well in our unit here. What can we do? I know that personally, when we looked at introducing our breech scanning into Drogheda, we went to the National Maternity Hospital and we contacted them, and they were extremely supportive of us, and they were absolutely fabulous, brought us up, gave us lots of training. I can't express enough. But to actually do that and pick up the phone, it was quite a difficult thing to admit. You know something, we can't do this that well, we're going to you for guidance. But it really is, you get such a response, and I think these conferences are great for getting to know people. But I think that we need to be able to pick up that phone and say, what way can we help each other? More midwifery input in care for all risk women, so making every contact count. It doesn't have to be your continuity of care midwifery. It doesn't have to be your community midwives, your midwifery-led units. Midwives should be there throughout the whole pregnancy, even if you are under consultant-led care and you're seeing that obstetrician. Why can't we still, alongside that, do all the midwifery care that we're doing for all the other women? Why do we have to risk those women out of that care that we know works, that we know they'll have better psychological outcomes, more positive impact on their life and their journey with their newborn baby and their family as well? Midwifery-led ECOS care and autonomous practice for normal physiological care and supporting that. Again, I know they spoke about the maternity strategy this morning and how it has made such a positive impact in some ways, and MWIP and the positive impacts that has made. However, you read articles like you read, I don't know if any of you saw it this week in the journal, about the home from home room in Sligo. And I don't believe that was fair on the midwives to discuss the room like that. I feel that in order for us to practice in a room and to be able to say, here is a room, we spent €100,000 in this fabulous birthing room, we need to know how to use the room. We need to have that support to be able to provide normal physiological care for women. There's no point in blaming the midwives. I think that midwives need to have that support, and that again has to come from the top down and has to come from each other. You know, we have to support each other. We have to support those midwives who are willing to go into that room and take that chance and say, no, I'm going to support this woman in what she wants, and I'm going to do that, you know, because otherwise it's not a good feeling. We know from our working in our midwifery-led unit what an amazing, not only for the women, but for ourselves, what it is to be an autonomous practitioner and the joy that you get from that. It helps with staff retention, you know, and it really is. It's such a joyous place to work that you want everyone to feel that, no matter whether it's normal risk, high risk, you know, we should be feeling that in all practice that we do. And I do believe, again, that our students are the key. I think that if we can teach them what normal physiological care is, then that will continue in the future. If we can show them and lead them the way as leaders, which we all are, we can show them that way in the future. And we need to be able to give women the accurate information to make their informed choice in a health literate format and to support them to make the right decision for them. Thank you very much.